Lisa Lawrence is a 32-year-old Primavera. According to her EDC, she is 24 weeks gestation. During this pregnancy, she has experienced no complications except that her pre-pregnancy weight was above normal. Her family history includes her maternal aunt and maternal grandmother have type 2 or non-insulin dependent diabetes mellitus. There is no known history of birth defects or other chronic illnesses in this family. During her exam today, she is told that her routine glucose challenge test was positive and that she will need to return for a 3-hour glucose tolerance test to rule out gestational diabetes.
So does this mean I have to take those pills my grandma and aunt do?
Perfect! Just take their pills. You don't even need a prescription. If you have 2 positive test results, then you will be diagnosed with gestational diabetes. As of right now, oral hypoglycemia agents are not used in gestational diabetes mothers. Until more studies prove its effectiveness in pregnant women, if you do have gestational diabetes, then you may have to start insulin therapy, which is a daily self-injection procedure. Many times, compliance to a diet and exercise plan will control this disorder.
We're preparing Lisa for a 3-hour glucose tolerance test. The nurse will need to explain that 3 days before the test, she will have an unrestricted diet of at least 150 grams of carbohydrates and will resume her normal physical activity. She will be instructed not to have any caffeine and to abstain from smoking 12 hours before and during the test. She will then fast the night before. On the day of the test, they will start off by testing her blood and obtaining her blood glucose level. She will then drink 100 grams of glucose preparation, and for each hour of the 3 hours, they will test her blood and record her glucose level. If there are 2 or more positives, then the nurse will go over a plan of care for gestational diabetes. Lisa's test shows that she has gestational diabetes. Since her blood sugar is high and uncontrolled, the physician has started her on 15 units Humulin NPH insulin and 5 units of Humulin regular insulin this morning and 2,000 calorie diabetic diet. Evening blood sugars at 5 p.m. are to be reported to the physician for an evening insulin report. The physician explains that she may be on insulin for the rest of her pregnancy.
So how long am I going to have to follow these rules?
Throughout your entire pregnancy.
The 3rd trimester, which in the case of Lisa, insulin requirements gradually increase until about 36 weeks of gestation. On the day of delivery, maternal insulin requirements drop drastically to approach pre-pregnancy levels. Breastfeeding mother maintains lower insulin requirements, as much as 25% less than pre-pregnancy. Insulin needs of non-breastfeeding mothers return to pregnancy levels in 7 to 10 days. At weaning of breastfeeding infants, mother's insulin needs return to pre-pregnancy levels. The nurse teaches Lisa how to draw up her insulin. Wash your hands. Check syringe and insulin for expiration and name. Roll NPH between your palms until it gets cloudy without shaking or getting air bubbles. Humulin NPH insulin is intermediate acting and stays in the system longer, for about 12 to 24 hours. Wipe off both vials with an alcohol wipe, inject 15 units of air into the NPH, and then inject 5 units of air into the regular insulin. While Humulin regular insulin is short-acting, which has an onset of 30 minutes, it peaks at 3 to 4 hours and lasts for 6 to 8 hours. Without removing the needle, invert the vial and draw 5 units of regular. Then draw up 15 units of NPH without injecting any of the regular insulin into the vial. Always draw up your cloudy insulin last. They are both ordered so your body receives insulin fast and remains in your body longer.
Could my blood sugar drop too low?
Not necessarily. There is a risk for hypoglycemia, which is when your blood sugar is too low, because of the medicine. You are also at risk for hyperglycemia, meaning your blood sugar is too high. And it usually occurs 2 hours after meals, so you will have to monitor it very closely.
Okay.
Signs and symptoms of hypoglycemia include pallor, sweat, irritability, shaky feeling, hunger, headache, dizziness, shallow respirations, and tachycardia. Glucose level below 60, impaired judgment, loss of consciousness, and inability to swallow, tremors, and may lead to shock and coma. Signs and symptoms of hyperglycemia include lethargy, thirst, weakness, nausea and vomiting, abdominal pain, signs of dehydration, flushed, dried skin, deep, rapid respirations, diminished reflexes, fever, increased urination, presence of ketones in urine, and fruity breath. Glucose level above 200, and it may lead to acidosis and coma. As a patient, contact your doctor immediately if you experience any of these symptoms. As a nurse, treat hypoglycemia by preparing to administer IV or IM glucogen or IV glucose, and treat hyperglycemia by increasing the patient's insulin. Other complications that Lisa may encounter are that she is at risk for hypertensive disorder and diabetic ketoacidosis. She is also at risk for spontaneous abortions and hydramnios. She is at risk for hospitalization if her glucose levels are not kept under control. There are an increased risk for fetal macrosomia, which leads to risk for dystocia, perineal lacerations, episiotomy, and cesarean birth.